Good evening, everyone. Thank you for joining us and spending part of your evening learning about CAMBRA and how it can help your patients in your own practice. We're really excited tonight to share the risk assessment practice data we've compiled over the last 2 years. But first, just a quick couple housekeeping items before we get started. You're all muted, so we can't hear any comments or questions verbally. Make sure to type any of those questions in the questions box on the right side of the screen. And at the end of the presentation, we'll have about 15 minutes to answer questions. We'll do our best to get through as many as possible. And if we don't have time for all of them, we'll get back to those via email. And we also offer one-on-one webinars for practices interested in learning more as well. But with that, I'd like to go ahead and introduce Dr. Kim Kutsch, CEO and founder of Oral Biotech in the CariFree system. Dr. Kutsch has successfully been practicing dentistry for 30 years and still practices 3 days a week here in Albany, Oregon. He's got a huge vision for curing dental caries, motivating him to start this company, and continues to motivate him in the research he's leading to improve caries diagnosis and treatment. He has a lot of passion for what he does, so it's always great to hear him speak. So with that, Dr. Kutsch, take it away.
Hey, thank you so much, Cody. And thank you, everybody, for being with us tonight and spending your evening, or if for those of that are on the delayed broadcast and are listening to the recording, thank you for spending your time with me. We've got a beautiful night here evening in Albany, Oregon, and so I appreciate it when you take your time to spend time with me. Tonight's topic is on, really I want to cover CAMBRA, Caries Risk Assessment, really talk about the form, and then talk about the data that we've collected in 6 different practices across the United States over the last couple of years. And we've got over 7,000 patient forms that we've collected the data on. We've got probably close to another, I would guess, 2,000 forms to input into the data. But I feel pretty good about the data that we have, and I think that there's some really interesting results there, and I think you'll find that interesting tonight. You know, so tonight I want to talk about a little bit of introductory stuff as well. We have over 300 people registered for this webinar tonight, and about 35% of you are first-time individuals to listen to a webinar from us. And so, you know, we always try and make sure that we cover the topic so that the people who are here for the first time, you know, kind of get a basis of that, and then the people, repetition is always good. You know, we learn that way. So tonight I want to talk about, you know, why CAMBRA, what kind of things you need to think about in terms of the road to get to CAMBRA in your practice. You know, and I am changing my presentations starting later this fall to really talk about at ground level in your practice, how do you actually implement this? We've talked a lot about what it looks like and with the science behind it and why you should do it and what we thought you might need in terms of information to actually do it. But the questions that I consistently get are really systems type questions, like who does what, where does it happen, which operatory, you know, what are the fee schedules like, what fee codes do you use, how do you follow up with a patient, it's those kind of things. And so we're going to begin the conversation on starting to answer those kind of questions so that you can more successfully implement CAMBRA into your practice. And one of the things you're going to need, obviously, is a CRA form, a Caries Risk Assessment form. We're going to talk about that tonight. We have some exciting news, if you haven't been aware of that we have CDT codes now for Caries Risk Assessment. And then I'm going to share with you our private practice data, and then talk about the book Balance that Bob Bowers and I wrote and we've distributed. You know, so, you know, why I'm here, when we get down to the why of CAMBRA, is tooth decay is out of control in the United States. It's the #1 disease now in the world in all age brackets and practically in every country. And so that's a real problem, and it's really a problem for us in the dental profession to solve. And we're not okay with that. You know, that's really, I spent the first half of my career drilling holes in teeth, and I've spent the second half of my career trying to help patients figure out what caused the holes in the first place, so maybe we can prevent that from happening. So I want to thank you for joining this mission with us. Bob and I wrote a book last year on Balance. It's really about, it's a guide on managing dental caries. It's really written for patients and practitioners to really describe the process, explain the science, and explain how to manage patients through that. But it really doesn't get down to that ground level of those kind of questions of like, well, you know, who who has the patient fill out the form, or who interviews the patient, or who discusses it with them, and how do you discuss it, and what does that conversation look like? So Bob and I have started another book, and we hope to have that done somewhere around the end of this year, but it will be all about implementation, and so we hope that we can help people with that. So why CAMBRA? Well, caries management by risk assessment is a new kind of standard of practice that's been, I've certainly been involved with for going on 13 years now, but it really evolves around risk assessment, and instead of minimally invasive dentistry per se, it really takes even a farther step backwards into the disease process to say, well, let's figure out what caused this in the first place and see if we can address and treat that. It's really a wellness concept in terms of healthcare, and it gives us the best opportunity to have the most effective care for our patients with the most predictability in the treatment outcomes. And the one thing that I think we don't look at enough in the dental profession is outcomes for patients. So the real question I have for you is, do you want to, this is what it boils down to. Do you want to spend the rest of your career drilling holes in teeth and filling them back up over and over again, or do you want to really sit down with the patients and find a cure, or at least an effective management for that disease for that patient, and really help them get decay-free? And I have to tell you, we're going to talk about ROI next month in our webinar, the return on investment of doing this. But I have to tell you, when you can take a patient who's had a severe decay issue, a lifelong decay problem, and you can make them healthy and decay-free, that's a life-changing experience for those people, and it will dramatically change your practice. And for the better, but it's, and financially it's better as well. So it's a win-win for everybody, but it's better care as the bottom line. But the question I ask you, do you want to do that, or do you want to really reach out and try and figure out how to help these people? And, this patient, I saw her today. She came to me as a new patient just about a month ago. And, she's really the poster child for me when I stop and think about this. This kid she's absolutely the sweetest kid in the world. She and her mother came to me. She's gone to 3 different dentists in the past, in her adolescent years. She has a total of 17 crowns in her mouth and 2 root canals, and she's about to get 3 more crowns. I want you to stop and think about that. I don't know when the last time you saw a 15-year-old kid with 17 crowns, but no dentist to date, nobody that had seen this patient had asked about, what do you think is causing this, or ask them about their diet, or ask them about, are they on medication? Nobody had stopped to ask them what was causing this disease in this kid's mouth. Instead, they just kept putting crowns on her teeth and did a couple of root canals to boot. So it's like, the question here is, do you want to just be one more of those dentists that keeps putting crowns on people's teeth, or do you want to stop and help them figure out what's causing it in the first place and provide a life-changing experience for them? And so that's really what the whole question of CAMBRA boils down to that. But this patient is just, like I say, she's like the poster child for this. And, when I started asking the questions and we had the conversation, the mom was like, nobody's ever talked to us about this. And we've wondered, why does she keep getting these cavities? And I'm talking serious decay. So the roadmap to CAMBRA can look kind of confusing, and it can look complicated. And what we've really strived to do is try and break it down and make it into logical steps so that you can break it down into step by step, because it's like it's the way to eat an elephant is like one bite at a time. We need to do this one step at a time in a logical manner so that you can be successful with it. Trying to change anything in your dental practice is not easy, and trying to change your behaviors and the behaviors in your team and your approach to care, it's not a simple task, but if you break it down and you take it incrementally, thousands of practices have been successful at doing that, and you can as well. So what do you need in terms of that roadmap? Well, the protocol for CAMBRA is really pretty simple. It's a flow. This is our flow diagram. It starts with assessment, and that's where we're going to start tonight. It can lead to testing if you want to use a biometric. We'll talk about that in the future. You come up with a diagnosis. You prescribe treatment, you discuss that with the patient, you deliver that care, and then you do your reassessment on them on a period of time. So the things that you're going to need, number one, you're going to need a caries risk assessment form. And number two, if you're going to use a biometric, you're going to need one. again, you're going to need to have a diagnostic protocol so that you have parameters for, low risk, moderate risk, high risk, and if extreme risk. If you want to do that, you got to put together therapeutic strategies. What are you going to do for each of these different patients? And then you're going to need to sort out what your fees are. Those are kind of the basic things that you're going to need. And over time, we'll go through these with you individually in great detail. And these will all be detailed well out into the book so that you, from a very generic standpoint, can look at this and make those decisions and come up with those answers for yourself. So we're going to start tonight by talking about assessment. And the way that starts is with a CARES risk assessment form. Now, there's primarily 4 CARES risk assessment forms that are available in the profession. I think you'll probably see more forms come to the market over time. Practically every dental school has their own separate CARES risk assessment form. I've seen forms that were 4 pages long. You calculated numbers and you came up with a numerical answer, and they had it's complicated, and I really just don't think that that's going to play well in private practice, because we don't have an hour to dedicate to this process. This is really something that we need to streamline, get to the conversation. I'm going to talk a little bit tonight about the usual suspects and that whole concept of pattern recognition in the terms of this disease. But basically, in my mind, there's 4 good CARES risk assessment forms on the market. The first one is from the ADA. Then you've got the one from the CDA, which is John Featherstone's form. We're going to look at that tonight. The American Academy of Pediatric Dentistry has their own form. We're going to look at it. And then, of course, CariFree has a form that we adapted as well. If we look at the ADA form, this is available on their website. It's free. It's a PDF file. You can download it. You can print it off. I think at some point in time, hopefully, and so we talk about the new fee codes, these are going to need to be electronic forms, and that's not really available at the moment. But over time, you're going to see these paper forms become more electronic. Now, the ADA form has some interesting features in it. Looks at fluoride exposure there at the top, and sugary foods or drinks, and you go down the list, and there's some questions there: eating disorders, unusual tooth morphology, restorations with overhangs or open margins, exaggerated tooth anatomy. You get into some of those questions, and it's like, well, I haven't really seen that validated in a clinical trial to know what the odds ratio is of, say, that risk factor and how that translates to a diagnosis of low, moderate, or high risk for dental caries. So, or let's say a finding, if you don't want to use the term diagnosis. But let's look at how those apply. And so here's one form that you could use, free and from the ADA. The California Dental Association form. This is the most current form that is free from. You go to cdafoundation.org. This is John Featherstone's form, and it has, you'll notice some similarities between this form and the CariFree form. It starts with disease indicators, moves through to risk factors, and then also lists the protective factors. In my own hands, the disease indicators I think are excellent, as well as the risk factors here. They're kind of in declining order of odds ratios, and this was actually the study that Sophie Damachine and Featherstone and the rest of his group did on 12,954 patients at University of California, San Francisco over a period of a couple of years. So they have kind of a large data pool of information to base those odds ratios and validate whether in fact these are disease indicators and or risk factors. The protective factors I actually found to be a little bit redundant, and I'm going to make a prescription in terms of my recommendations for patients, and so I really didn't include that in the form that I use. But again, this form is available. I like the concept of the caries balance at the bottom. Certainly everything that's on this form has been validated in a clinical trial that's been performed at UCSF. So that's another form that's available. And this is the study actually that was published then in the California Dental Association Journal back in October of 2011. That study, again, if you want to read all of those articles from both the October and November issue of the CDA Journal, those are archived permanently at cdafoundation.org. under journals. And so you can go look at that and pull up all of those articles if you don't have a copy of them and read through them. I know that I wrote one or two articles in those journals as well, particularly on implementation and integration of CAMBRA into private practice. But the interesting things, again, you've got your caries risk, you've got the disease indicators from this study. Have they had a patient that had a restoration in the last 3 years? Do they have proximal lesions, or we need to describe that as radiographic radiolucencies interproximally? On the radiographs, are there active white spot or progressing white spot lesions? And then are there visible cavitations? If they have any one of those, the patient has a disease. They're high risk. Now, we look at the risk factors themselves, and those have all been documented and validated, again, in this form and in the study. And then depending upon your biometric, you could look at, you could culture bacteria, or in our case, we recommend looking at the ATP of the biofilm. But interesting, in this study, 15.5% of the patients at the dental school were classified as low risk. And in private conversations I've had with John, who is one of my mentors and I think just one of my all-around heroes, John said they may be over, or let's say underdiagnosed those patients, that may be overstating actually how many patients were truly low risk, as a number of those, something like 28% of those patients that were classified as low risk in the study actually developed a new lesion like in the first year. 22% basically were moderate risk, and about 63% there were high or extreme risk. And so I think that's kind of an interesting profile of dental school patients. We're going to compare that data to what it looks like in these private practices before we're through here tonight. You've got the American Academy of Pediatric Dentistry. This is their form. And again, this is available. It's available on their website. You can get it in a PDF file. You can download it. You can print it off. You can use it. Now, this is for patients that are 6 years and older, but you have to understand there's some pretty strange questions in here if you're going to be actually applying it to adults. But in a typical pediatric practice, they're not dealing with adults. They're dealing with children, or let's say adolescents. And we break those groups in the below age 6 and over age 6. But questions like, is the patient a recent immigrant? Are they low socioeconomic status? Now, the data is very clear in terms of there's been a lot of studies that indicate children, if they're of low socioeconomic status, they're virtually 100% of those kids are high risk for dental caries. It's not a cause and effect, but there's a very strong correlation there. Now, as somebody that's 30 or 40 in your practice, that may not necessarily be accurate. In fact, I haven't seen any data on that. So, there's some questions here that may not necessarily apply. But again, that's a form that's out there and it's available. One of the studies that was published just this last year in JADA looked at the AAPD caries assessment test and compared it to, in this study particularly, looked at a population of young, low-income Hispanic children, and actually just salivary culture of mutans streptococci outperformed the caries assessment form that they use as a predictive factor for determining future decay, accurate in terms of sensitivity and specificity. And I think certainly one of the issues for us is there's not a lot of sensitivity and specificity studies on caries risk assessment forms. So I think we need to be honest about our science, the level of our science. There's still more science that's going to come and develop as we continue on this journey, or the evolution of caries management in dentistry. But we have two choices. We can continue to advance the ball with the science that we have, or we can stop and not advance the ball at all and just hope that wait 15 years and watch all these kids continue to get decay and have problems. So, which is not an acceptable option. What we're doing is not working, so that's not an acceptable option to me. So, in terms of using that form, the culture is maybe more predictive than using the risk assessment form, at least in that population in that study. Then you've got the CariFree form. This is one that I actually helped develop, and this is what I use every day in my practice. And this form is different from the standpoint that all the previous forms are filled out by the dental professional, which means that it's somewhere in your patient appointment time, either the dentist or the hygienist or the assistant needs to sit with the patient and interview style, help them ask them the questions and fill out the form. And that takes quite a bit of time. And then it's also leads into a territory of me identifying something and telling a patient that they have a problem that they're not aware of that they have, or they don't think they have. And those conversations are always challenging, particularly when the patient says, no, I don't, no, I haven't, no, it doesn't. That leads to some challenging times. So the thing that we did to the start of this form, everything above the gray line, if you haven't seen this form, everything above the gray line is filled out by the patient, either at home before they come in and they bring it with them, or it's filled out by the patient in our reception area. So prior to being seen or seated, and typically this is done prior to the hygiene appointment, either as a new patient or as at their recall. Once a year we collect a form on every patient. And so, the question, that we ask then at the start is we have them fill out the top. It changed the dynamic incredibly in my practice. It went from me trying to tell them what I saw, for them actually reporting to me things that they identified in their own mouth. And so as you see some of that data tonight, I think it'll, raise your eyebrows a little bit. And then it's a whole different conversation. It's no longer me trying to convince a patient that they have a problem that they don't think they have. It's more about me helping a patient determine what they can do about an existing problem that they've identified for themselves. And we start at the top with 3 motivational interview coaching type questions. We're asking them, are you interested in a free screening today? And, if you're diagnosed with cavities, would you be willing to talk about different options on how to manage those? And then last, if needed, would you be willing to change your diet if that was necessary? And that kind of gives us a feel for where the patient is at in terms of that motivational interview. Are they aware that they have a problem? If they have a problem, are they ready to start doing something about it? Are they thinking about it? Are they in that contemplative or pre-contemplative stage? And so it kind of gives us a feel for where that patient's at. And if the patient has a lot of decay and they said no to the first question, it gives me the opportunity to say, gee, I find this really interesting, and open the conversation with, we have a test and we can start to look at what might be causing this disease for you and all these cavities, and you're not interested in this free test. I'm just curious, is there any reason for that? And it starts the conversation, and they may still not want the test, but at least it helps you in terms of your behavioral management with the patient, start to develop a relationship, and you can start to understand where the patient is at in terms of the readiness to do something about that in their mouth. And then, of course, they identify their risk factors. On the bottom half of the screen, this is filled out by the professional, and you'll notice that the risk factors are straight from the Featherstone form. The disease indicators are straight from the Featherstone form. The biofilm challenge is the ATP that we use, that I use as a biometric. And then below that, we have a professional assessment summary to try and figure out whether this patient is low risk, moderate risk, or high risk, and within that, kind of how do they fall within that category. But again, it's like I like to have the flexibility to look at that and say this is a concern to me or not a concern, so that we do a little strategic or critical thinking in the process. It isn't just a yes, no. It's actually, okay, they had one filling 3 years ago. It's the only filling in their mouth. You don't see any other evidence of decay. Is that disease indicator a concern to you? And if it's not, then doesn't make them exactly high risk. So we need to be able to apply some critical thinking as we go through the process. And then we can plug them into 1, 2, 3, or 4, 5. And then that, of course, leads to a more simplified approach in terms of our treatment decisions. But it leads into the conversation that the concept I've been trying to teach for the last couple of years in my programs is the concept of the usual suspects. One of the things that I've started to recognize a few years ago is that what I typically see in my practice is I see a usual pattern of this disease, and patients tend to fall into one of these kind of categories. And if you can very quickly kind of get a sense for where they're at, you've got this pattern recognition working for you, and it makes it a lot easier for you to figure out where you're going to go or what conversation you need to have with the patient. When I was in dental school, the usual suspects for this disease were mutans, streptococci, and lactobacillus. It was an infection of those 2 bacteria. They had high levels of those 2 bacteria, and that was end of story. That's what caused the disease. And now we know that it's a lot more complicated than that. And so when I look at my usual suspects today, number one is bacteria. It's still bacteria. That's one of our issues. And typically, in that pattern, I see one of two things. They either have too much bacteria on their teeth. They have too much visible plaque. They've got too high of a bacterial load, okay? And that could be related to then home care and diet. Or they've don't have a lot of bacteria, but those bacteria are behaving very badly. And so they've got a lot of acid uric behavior of the bacteria on the biofilm that they've got. Next is diet, and typically the patterns that I see with diet is one of two things. Again, they're consuming way too much simple sugar in their diet, or they're snacking too frequently. And if we go back to that Stefan curve, we know that it takes 15 to 30 minutes in a normal, healthy mouth for the pH to recover, from the saliva and the other bacteria that are present. And if you eat again within that window, you've got you drop the pH again, and so you continue to contribute to the selection pressure for the wrong bacteria and wrong behavior of the bacteria. So it's not just what you eat, it's how frequently you're eating as well. And so that's one of the usual patterns of this disease that I see. Saliva is typically, if they have a salivary issue, it's because they don't have enough saliva, and if they don't have enough saliva, it's typically because they're on multiple medications that are contributing to their hyposalivation. Now, one of the most recent usual suspects for me is really this whole concept of genetics. And there have been 11 papers published in the last 2 years looking specifically identifying different genes and polymorphisms of those genes and as they relate to an increased risk for dental caries within populations. And so we're going to see more and more about genetics and the influence that has on a person's risk for dental caries, but I can't really genetically test people right at the moment, so that makes that a little bit challenging. However, there are patterns or phenotypes of that disease, expression of dental caries in the mouth that we can begin to look at. And of course, at the end of the day, this all comes back to old Kaiser Sose, and it's all about the pH. This is a disease of pH. But we can use this pattern recognition to look at this and help us kind of simplify the process. So I talked about bacteria as being one. Now we know that there's over 50 bacteria that have been identified as potential cariogenic bacteria playing a role in this disease. The most recent one was reported in the Journal of Caries Research in January of this year, Propionibacterium acidifaciens. We continue to add to that, I guess, to the list of suspects there that we need to deal with. But the more complicated this gets from a biofilm and a number of bacteria, the less specific it gets. So if we're trying to treat this with a vaccine, or if we're trying to treat it, in the manner with an antimicrobial agent or a specifically targeted antimicrobial peptide, and you've got 50 different pathogens that could be causing a disease for a patient, that's going to make that kind of concept a little more challenging for us. When we talk about diet, and if you haven't looked at this, this is in the National Geographic August issue. There's a really good article on sugar and Americans and sugar. The average American eats 22.7 teaspoons of sugar per day. And when we talk about high fructose corn syrup, Americans are number one. We eat 51 pounds of high fructose corn syrup per year. Now, the article talks quite a bit, goes into detail about how most primates are extremely efficient about processing fructose, and this is kind of something that we developed as a mechanism that allowed us to survive better. The fruit's only available, seasonally, once a year, and our bodies being able to take a very low amount of fructose and metabolize it in the liver and produce adipose and abdominal fat. And, so from a very small amount of fructose, we're able to highly store and save that energy. And so if you think about that, and we're programmed to do that genetically, I mean, that's, from an evolutionary standpoint, that's how we've developed. And then you start feeding us 51 pounds of it a year, and then you look at the body type of Americans today and what's happened in the last 30 years and in terms of obesity and hypertension and heart disease, you go down the list, there's probably a direct link between those two. It's a very interesting article. We're not in the top 5, however, of total refined sugar consumption, but it is a problem for us. sugar in our diet is certainly contributing to this disease on a national basis. I thought it was very interesting, something I didn't know until this article came out. Cotton candy, which is just basically electrified sugar, was actually invented by a dentist. So I probably, working on job security, I have no idea, but I thought that was rather interesting. And then we talk about saliva. This is just out. This is published in June. This study is from the Journal of Mayo Clinic Proceedings, and this is June 2013. And when we talk about saliva, they could have low or poor buffering capacity of their saliva, but the typical pattern I see is xerostomia. We're trying to, use the term hyposalivation now. Today, that's a better term to describe the condition than xerostomia. But in this study report, looking at patients from the Mayo Clinic, more than 70% of Americans take one. Now, this is seniors, adults, and children. 70% of Americans take one prescription drug per day. And this is from 2011. Now, if you look at some of the CDC information, it's lower than that, but that dates back to 2007. In this Mayo Proceedings, more than 50% of Americans take 2 or more prescription medications per day, and 20% take 5 or more prescriptions per day. In 2011, there were 4.02 billion prescriptions written in the United States for $320 billion. There are now 6,497 drugs listed in the PDR. So I think that this is, in many of those, the number one side effect is dry mouth, and the more of these drugs that they take, the more complicated that becomes. And so I know that you guys are all dealing with this. This is an issue in my practice. This is an issue for all of us. And I don't really have the answer. The answer, I think, goes back to diet, exercise, and our overall health. But certainly the number of medications that we're taking in the United States is growing, and it's alarming to me as a health provider. And then genetics, and I just want to share this quick photo with you. This is a 12-year-old kid that came into my practice in January, and this study was published. This was a genome-wide association study reported by Schaefer and Feingold. They did 2 studies that they reported this last year in the Journal of Dental Research. And I was reading this over the holidays, and this, one of the genetic links, they looked at like 518,000 gene sites and looked at over 970 patients, adults from the age of 18 to 75, and they found 11 major gene associations, and they actually found geographic patterns of decay in the mouth, and so they actually identified them as different phenotypes of dental caries. And one of them that came from the study was from the lysyl-2. Lysyl-2 influences a bacteriolytic enzyme. It's a protective enzyme found in the saliva. And one of the polymorphisms of lysyl-2, or where the patient was deficient in lysyl-2, it ended up with them being associated with a high frequency of decay of dental caries lesions in the mandibular incisors. Now, I have to tell you that those are the last men standing in this disease. Like if a patient has 6 teeth left, we all know which ones they are. If they have 2 teeth left, we know which ones they are. So to tell me that there would be an expression of this disease where the patient only had cavities in their mandibular incisors, which is where most of the saliva and all the protective factors are, that's the only place that they would have decay. I read the article and I thought, I don't think I've ever seen a patient like that. That doesn't pass the smell test with me. It's like, yeah, it sounds great, but I've never seen it, so I'm not sure this is for real. And literally 2 weeks later in January, a mother brought this new patient in to see me. Been seeing a pediatric dentist. They've refilled these mandibular incisors like 2 and 3 times. It's the only decay this kid's ever had has been on the mandibular incisors. And I'm looking at it going, holy cow, this is exactly that phenotype number 2 that they were describing in their study. And now I've seen 2 more patients since then that have the same expression of the disease. And when I explained it to the mother and what I saw was going on here, she said, I've had the same issue. And so the mother's had the same problem. And so, now I have a case study of 2 people but I think that it's interesting when we start to look at these genetic expressions of the disease. We can maybe start to identify the patterns, even though I can't test for that, test their DNA or test that gene specifically yet. I can start to look at patterns of this decay and go, oh yeah, that appears to be an expression from this. So I can tell you, I can't correct that. I can't correct your lysyl 2 deficiency, but what we can do is figure out what it takes to be able to manage around it so that you can stay healthy. And so at least, the mom looked at me and said, our pediatric dentist told us that you would know what was going on. And I'm absolutely glad that I had read that article. So there are 4 forms that are available. We've kind of gone through them rather quickly tonight, but here's the bottom line. Pick one. Write it down, make a decision. If you're going to build a roadmap for yourself, do the strategic planning and implement this, pick one. I don't care which one you use the one that makes the most sense to you, but pick it and use it. The next decision, you have to figure out who you're going to use it on, who's going to fill it out, and, all of that. And that's, the next step in the process. But the first step is you need to pick which form that you want to use. And one of the things that I mentioned just a little bit earlier tonight was, and being, full disclosure on our science here, the evidence for the validity on our caries risk assessment forms is limited. We don't have meta-analysis, systematic reviews of clinical trials. There isn't that kind of data available, and there's not going to be a lot of those. Those studies are very expensive to conduct, and in the economic environment that we're in right at the moment, which I don't see changing anytime soon, we're going to have to learn how to get by without systematic reviews and meta-analysis on 95 different clinical studies and throwing a couple out. And we're going to have to take the best scientific evidence that we have available to us and make the best decision based on that evidence and move forward. Or we're going to have analysis paralysis as a profession. But the reality is sensitivity and specificity studies is limited, and that's just where we're at. But we do have a large clinical trial that was done by Featherstone's group at UCSF that did validate the odds ratios on all of those disease indicators and risk factors, and so that's why I went with that. By the way, another just moment of disclosure here, when you see those same risk factors and disease indicators on the CariFree form, we've used those with Featherstone's permission. So John wants to share those with the world, so it's like anybody's free to use those. But that's where we're at today. So I mentioned earlier, too, the new CDT codes. I'm excited about this. We have 3 new caries risk assessment codes that are going to be new for 2014. We have D0601. It's a caries risk assessment and documentation with a finding, not a diagnosis, but a finding of low risk. So it's really important for us all to be clear about these are not diagnostic codes. We do not have diagnostic codes in dentistry. That's a whole other topic and a debate on whether that's good or bad, but the reality is we don't have diagnostic codes. These are reported findings and using a recognized assessment tool. And so if you have a question about which is a recognized assessment tool, I would share with you, in my opinion, the 4 forms that you've seen tonight would all qualify as a recognized assessment tool. But that means that you filled out a form. And then you've got D0602, caries risk assessment documentation with a finding of moderate risk, and D0603, caries risk assessment and documentation with a finding of high risk. Now, I was at a CAMBRA meeting, the Western Coalition of CAMBRA organization, just a week ago on Wednesday, spent the day at University of Pacific. There were almost 50 of us in the room, a number of individuals representing stakeholders from the dental insurance industry. And they're excited about this code. They want to see this whole process move forward as well. They recognize that certainly there's potential for abuse here, that somebody could claim they've done this and they haven't done it, but all of the companies that were present are willing to move forward. And I think that one of the things that we'll probably see is these become more, the forms become electronic or digital, that will probably, along with your electronic billing, you probably just send the electronic form with that. And so I'm excited about this. I mean, this is the first step. Yep, we need more CDT codes for caries risk assessment and management, but this is a huge first step. So I applaud the CDT and the ADA for making this happen. This is an exciting time for us. We've been waiting for these for about 12 years. So I'd encourage you to start using these forms. Now, just because we have the CDT codes doesn't mean that you're going to automatically have coverage for each of these codes on every plan in your area. But if we start using the codes, it's up to us to argue the case to the employers and the employees that there's value here and that they should cover that and that they should look at doing that, that they should purchase insurance plans that cover this kind of care. So that's going to fall on our shoulders yet. So what I want to share with you tonight, which is the main topic here of our whole webinar, is private practice CRA data. This is from 7,328 patients. We have 6 practices. Mine was one of them that participated here across the country over the last 2 years. And we've collected these forms and inputted them, electronically inputted the data one by one. And we did a CAPA calibration, basically a training on every practice in terms of what constituted low risk, whether where was that risk factor a concern or not a concern, so that we were all on the same page. So you should have a pretty high degree of confidence in the data that we've got. So starting at the top, the first 3 motivational interview coaching questions, behavioral management questions on the CariFree form, 69% of the patients said yes, that they would be agreeable to having a free screening test. Now, you also can have a modified form that you can charge for that test if you want to. So, but on the forms that we did in the study, it was a free bacterial screening test with the ATP test. 69% said yes, and basically 31% said no. That's a very interesting number. I find that interesting from the standpoint that, if I went to my physician for my annual physical and they said, would you like a free blood pressure check? I can't imagine somebody saying no to that, but my physician assured me that if they actually offered it as an option, there would be a good number of people that would not want to know what their blood pressure was because they just don't want to know. And they'd rather live in ignorance than to deal with know about a problem and then have to deal with it. So that's partly human nature. Would you be willing to discuss treatment options? Now, interestingly enough, 69% said yes to the swab, but only 59% said, yeah, I'd be willing to talk about it if I had decay. So I think one of the things we need to appreciate from our patients is they're not yet sure what all of this means. If discussing those treatment options, and maybe if you use one of those options, you could be decay. We could show you how to be decay-free for the rest of your life. Would you be interested in talking about that? Of course, we'd all expect that everybody would say, there'd be 100% of people would say yes to that, and there are probably literally only 70% of people would probably say yes to that. And I found the last number really interesting because human behavioral change is not easy. At any age, modifying your behavior is always a challenge. It's not easy. And so optimistically, 69% of people said that they would be willing to modify their dietary habits. Now, what I find interesting when you look at this, 69% of the people were willing to have the screening, and 69% of the people were willing to maybe modify their dietary habits. What I don't have in the data is to know whether those are the same 69%, but I'm pretty sure that they are. So I think that's kind of interesting, and they're optimistic. Now, we talked earlier about the usual suspects looking for pattern recognition, and we talked about those individual risk factors that have been validated in the Featherstone study. Then, if you look at these, so these are percentages of the patients that had this risk factor in these, 7,300 patients. Over, number one at over 60% was snacking too frequently. Number two was drinking things other than milk or water in between meals, or more than 2 or 3 times a day. And number 3 on that list is medications, and we had close to 60% of patients were taking at least 1 prescription medication a day. So I would tell you that our data is pretty close to the Mayo Clinic data in terms of how many patients are taking prescription medications. Now, in terms of plaque, you see that number there is closer to 40%, and then dry mouth that's lower in appliances, and the other we lump together, recreational drugs, eating disorders, and all of those kind of into that category. But if you stop and look at this, number 1 and number 2, drinking and snacking, those are dietary issues, right? And so those are behavioral issues. So the 2 biggest risk factors that we identified are behavioral. And so that gives us an opportunity if we can help them with a behavioral change. That's really good news because those are things that patients theoretically can change. Next on the list is medications. That may be lifestyle associated as well in terms of their diet and how much exercise they get. It may not be. It may be a genetic thing for them, that they're dealing with. But medications are next on that list. I can't take them off their medications. I need to learn how to, or I need to figure out what it takes to help manage that patient through the dry mouth because of the medications. And then, the next one is plaque. And again, plaque is a behavioral issue. So we're talking about home care, brushing and flossing. And again, theoretically, that's something that we can help the patient modify. So, the 4 biggest risk factors, 3 of them are things that are behavioral related, and that's good news for us because theoretically we can do something about that with the patient. Now, I found this very interesting. When we looked at the disease indicators, the number 1 disease indicator in all of these practices was a history of decay, and a history of decay or restorations within the previous 3 years. And we didn't break it down to, do you know why you had this filling? And patients don't always know, and they're not always clear about when they last had a filling and why they had the filling. But so we're depending upon their memory in terms of taking that data and trying to make it meaningful. But again, we ask the patients, or we ask the practitioners, the dental professionals, to make a decision based on whether they felt that was something that was a concern. Number 2 on the list, obviously, was visible cavitations, which you'd expect, and certainly then the interproximal radiolucencies and white spots were at the bottom of the list on that. So the most frequent of those was really a history of decay. When we looked at then how do these patients profile, and I think this is interesting, extreme risk was the highest. So these are patients that had disease indicators and risk factors and had a high biofilm challenge. So had a high ATP score. So these are people that have all of those things. It was yes, yes, yes as you go down the form. That was the largest number of percentages of patients, and that's in my practice. And I was kind of, I guess, interested to see what it looked like in other practices, and we got the same kind of data. The second largest group in this was the high-risk patients who have they've got a high biofilm challenge, but they don't yet have any disease indicators. And that, again, is a group that we can do some preventive care with to try and lower their risk in terms of their biofilm challenge before they start to get cavities. The high-risk group there that's in the middle, be squeezed between there, the patient type number 4 in the CariFree group, these typically are people that have low biofilm challenge, but they have cavities. And so I'm looking at that group, and typically what I see there is a saliva issue, and or I'm starting to put the genetic patients into that group as well. So the patient that I showed you at the start tonight, the 15-year-old, here's a kid that has 17 crowns. She's about to get 3 more. She's going to have 20 crowns. She's 15 years old. All those crowns are primarily on her posterior teeth, and her biofilm challenge is low. So it's like, that's an interesting, that's an interesting finding, I think. But when you start to look at the moderate, low, and moderate group and the extreme risk, we got about 66% of the patients were high or extreme risk, and the rest were like 30%. And so our data wasn't very far off of what Featherstone's data is on those 12,000 patients. So again, I feel pretty good about the data that we've collected in terms of how these patients profile. I would tell you that our low risk differed from Featherstone's data that was at about 15%. Ours was at about 3%. And so I think we're probably a little more critical, or maybe did a better job of who is truly at low risk. But you stop and think about it. when you look at the definitions and you look at the ADA's definitions of low, moderate, and high risk, 3% of patients in private practice are low risk. So that means other people have risk factors. They may not have cavities, but they have other risk factors that at least it gives us an opportunity to present that information to them, educate them on what the risk factors are and how we can help them lower or modify their risk to reduce their risk going forward for future decay. Now, one of the other pieces of data that we collected, and I didn't break it down for you here, but we looked at one of the other things we looked at is, did the patients decline to do anything, or did they do what our best recommended caries management plan was, or did they just maybe didn't pick the optimum plan, but they picked to do something rather than nothing? And so in my in the overall group, about 57% declined. Almost 7% did the optimum treatment, and about 36% did something rather than nothing. And when we look at human behavioral studies, when people are given an option, and one of the options is to do nothing, typically 50% or more, just slightly above 50% of patients will choose to do something rather than nothing. And so our data is fairly close to that. I could share with you that in my own personal practice, my data is right at 51%. And so, but I've been doing this for 12 years. I've been working on wellness coaching and motivational interviewing, and being able to have those kind of conversations more effectively. I think the longer that we do this, the better that we get at that. The one question that you might be thinking is, so which of the patients did what? And I would tell you that up there in the recommended treatment, the people that did the recommended treatment, virtually almost all of those patients were in the extreme risk category. The people that really have dental problems went for the entire therapy. They wanted to eradicate this, do everything they could to improve their health. And I would tell you that almost 100% of the patients that were low risk decided to do nothing, and I think that's appropriate. I mean, why do you need to do anything if you're healthy? All you need to really do is just stay healthy. And so then it broke down between the moderate and the other high-risk patients. Kind of, some of them decided to do it, and some of them decided not to do it. But again, that comes into conversations that we're going to cover going forward on how do we, what do those conversations look like? Obviously, this is not a 1-hour coaching appointment. How do we have a 7-minute meaningful conversation that can help patients make, sustainable behavioral changes? And so that's pretty exciting as we talk about that going forward. In fact, actually, I didn't realize that I had this slide broken out, but you can see that most of the patients that were low-risk decline treatment and the people that did the highest degree of people that did the recommended treatment were in the extreme group. So that kind of gives you a look at how these patients profiled out. I would tell you, too, I'm pretty excited about the fact that a lot of the patients in the first high-risk category were choosing to do something about it to reduce their risk before they started getting cavities. So that's really good news for all of us. So we wrote the book Balance. If you haven't read it, we'd love to send it to you to read. It explains kind of the whole management process and the theory behind it. It's been out it's been out almost a year. I got the first proofs back in August a year ago, and we started sending it out to people in September. Interestingly enough, we have 49,500, as of today, we have 49,524 copies of this book in circulation. Most of those have gone to dental professionals. A good number of those have gone to patients. We have, I think, 32 dental schools and 37 hygiene programs using the book in some capacity, and then others have gone out to government agencies or insurance companies or other people that have requested the book. But that's kind of how that profiles out. So the good news is the book's gone out to a lot of dental professionals. I give the book out to my patients, particularly the patients that I find that are really high risk, and I want them to go home and read it and take notes, dog your pages, tell me if you see yourself in the book. If there's something we haven't discussed, make notes and bring it back and let's talk about it, because the more information, the more data I have, the better I can help you, conquer this disease. So I want to thank you all tonight for tuning in. I hope that some of this was new information for you. For those of you who have been, attended, 10 or 12 seminars or more, I hope that I provided some information for you tonight, too, that helped you or that you found interesting. And for those of you that were with us the first time, I encourage you to return and join us on some webinars in the future as we talk about, the return on investment or CAMBRA and realistic treatment expectations for patients, and how we're going to continue that conversation on implementation step by step, and we're going to continue working on that coaching conversation and how do we work with the patient on that. So I want to thank you, and we're actually done right on schedule here, and we have time for a few questions. Cody, I know that we always get some great questions from our attendees, so fire away.
Awesome. Yes. Thank you, Dr. Kutsch. Yeah, and we do have some good questions that came in, so I think we have some time for a few of them. I'll start with one that's kind of surrounding the data. I think this is a great question, but what are the most positive changes that arrived in your practice after being able to visually see your patient's risk data?
Okay. That's a great question, Cody, and I would tell you that for me, being able to see that data really gave me an idea on how this disease profiles in my practice. And if you go back to looking at the number one risk factor, that we saw was snacking and their eating behaviors, and number two was what they're drinking, and number three was medications, and number four was, too much plaque or too much biofilm. Having that kind of data, armed with that kind of data, I know that more often than not, one of the things that I need to be looking at on that risk assessment form and going through very carefully in detail with that patient is, what are you snacking on? How are you? Tell me how you eat. What are you eating? What do you eat in between meals? And having that kind of conversation. And it's really good for the rest of my team. In fact, we're going through this data again tomorrow at my team meeting at my practice, so that everybody's really aware of what our patients look like. What is this disease? What is that distribution? What do those risk categories look like in our practice? And again, having the information too for my team, in terms of having those conversations with the patients about helping that patient make a decision to pursue some kind of management of the disease, knowing that, where are we at here? In my practice, we've got right at 50% of the patients are choosing to do something, but armed with that data, we know that we can get better at that. And where are the opportunities for us to help patients and improve our outcomes? And so having that information, I think, is helpful. Even the motivational interview question, having kind of the data, it's like not everybody's going to say yes. And when they say no, what do we do about it? Do we just ignore it, or do we ask the question, gee, I find that interesting. Tell me more about that. And not being judgmental, just being curious. And that opens the door to a lot of conversations. So I think having that information that's been very helpful is I've been following, tracking our own data for about 5 years now. But being armed with that data, I think it helps the practitioner have a little clearer image of what's happening in their practice and where do they need to look. What kind of things do you need to be looking for? It also kind of validates in my mind the whole concept of those usual suspects that I've been teaching for years, and that whole pattern recognition. That kind of confirms in my mind that we're on the right track with that kind of approach. Great question, Cody. Thank you.
Great. Thank you. And I have another really great one that they asked. That was with regard to the screening acceptance. Your screening acceptance rate is higher than what I've experienced in my own practice. What do you think would contribute to that?
It's really how it's presented to the patient. Like when I first started doing this, I literally thought that it would be like 95% would say yes. I mean, I could not imagine that if I went to any professional and there was a free screening test for something about my health while I was there, that I would say no to that. And so it's kind of like, that kind of caught me off guard, and so I started asking my team. It's like, well, what do you think is going on here? I don't understand this. And some of the first responses that we got as we started asking the question was the patients, well, they didn't want to pay for it. And literally, I mean, how much is it going to cost? Well, free. It was FREE. What part of free, did you not, didn't you get, right? They literally, even though they read it and read that it was free, it's still associated, because I think I think we've been burned enough on it. This is going to be free, but there's always some string or attachment or cost that they started to do that. Number two, the second most frequent resistance that we found was that patients thought we were going to be like poking them with a needle or drawing blood or something. And so they were scared to have that done. So when we started handing the form to the patients at the front desk, and my receptionist said to the patient, oh, by the way, the first at the top, would you like to have a free, we can screen for you today. And by the way, it involves just taking a swab, like a Q-tip, running across your front teeth, and it takes like 15 seconds. That's all we need to do. And by the way, there's no charge for that. Our acceptance rate went up dramatically. So my acceptance rate in my practice is higher than 69%. But again, that comes from, I think, how it's presented to the patient. So not only does it say free and it's a swab or whatever, explaining it to the patient, I think, makes it a little clearer so they don't have fear about pain or cost. So those are the two objections I think that we've heard pretty much universal objections, and then the third objection might be how long is it going to take? I mean, those are the three objections to all dental treatment. And so it's no different with a free screening test. Great question.
Great. And so I think we have time for maybe two more. What do you see as the main difference between the 4 CRA forms?
That's another really good question. Well, 2 of them have been validated. Each line item has been validated in a huge clinical trial. So let me say that to start with, and I think that's probably the main difference between them. I think that I really favor, Featherstone's data, and so, for me, I'm looking at either the CDA form or the CariFree form, and of course we use the CariFree form because I like the management. The first 3 forms that I showed you, the ADA, CDA, and the AAPD forms have to be filled out interview style. That takes a lot of time wherever you're going to do that. It could take 10 or 15 minutes in a hygiene operatory. You throw that onto an already packed hour in a recall appointment. Managerially, that's an issue. That's a capacity issue in that appointment. So that became a huge issue in my own practice years ago. So that's one of the main differences. The CariFree form is filled out by the patient. From a behavioral standpoint, the thing that's huge in my mind is I no longer try and convince a patient that they have something they don't think they have. They're actually reporting it to me. And this is an interesting data point. This survey that was done, published 2 years ago in JADA, indicated 7% of patients self-report dry mouth. And in my practice, 27% of patients report dry mouth. So based on that form. So it's been really successful in terms of patients being able to start to identify challenges or issues or risk factors that they have, and it opens the door for risk factors because they start to think about it as well. So those are the differences in the forms. I would say clinical validation, ease of use, how you manage it within your practice, and that's the main difference. There's a couple of questions, I think, or risk factors and things on the ADA form and the AAPD form that I don't think they don't make sense to me. Number one, I haven't seen them validated, and number two, I don't think that those questions necessarily play well on adults in a private practice. So I would just share that information with you. But again, I don't care which form you use. There's 4 forms out there. Pick one.
Great. Okay, and I think we will end the night tonight with a question kind of related to conversations with patients. I think that's obviously extremely important in implementing anything. I struggle with the complexity of the conversations we need to have with patients to assess the risk, mainly because it is so complex and they're hard to keep on track. What are your best practices for a team like ours struggling with this aspect?
Cody, that's another great question, and I think that I've been studying wellness coaching for the last 3 years, and learning how to have a meaningful conversation in a very short period of time, instead of telling people what they have and what they need to do, we're a lot better off, or we're a lot more effective by asking them questions. What would you like to do? here's what we have found. What would you like to do about that? And, in spite of the fact that we tell people that they need to brush and floss, the number of people that actually floss in the United States is in single digits. So telling somebody to do something doesn't make them change their behavior. And telling them what the risk or the downside or the outcome of not doing it, no matter how scary that is, doesn't change their behavior. So it's really, when we get down to asking questions, what would you like to do about this? Are you concerned about the disease you have? Or are you tired of having cavities? How would you solve this? And so those are coaching questions, and we start to get the patient to participate. And actually, what we've discovered is trying to help the patient make one change at a time. I don't ask them to make 8 behavioral changes and do 6 new things every day. Just trying to help them get one behavioral change at a time is really the best way to go. And I used to be, it's how we were trained as professionals. We're trained to see what we see, tell the patient what they need to do, and then tell them the order in which they need to do it. And here's what you need to do first, and here's what you need to do second, and here's how you need to approach it. And when I separated myself from having to own control of what order the patient was going to make those behavioral changes, we got a lot more successful as well. Rather than me telling them that they had to start here and do this first. So if they've got to change their diet, they need to improve their home care, and I need to have them start with this rinse, and we need to restore their teeth, rather than me telling them, okay, this is what you need to do first, this is what you need to do second, this you have to do third. What I found is that when I ask the patient, what would you want to do first? And typically they make really good decisions for themselves, armed with enough information. And when they have control of the situation, the one that they're most interested in changing first is the one they're going to be most successful at, probably. And so if I'm trying to get them to floss, but they're more interested in changing their diet, and I force them to try and floss first, it's probably not going to be successful. Whereas if what they tell me is, I really want to work on changing my diet first, it's like, you know what, let's talk about that. Let's figure out strategically, give you the steps and the tools on how you can accomplish that. And if they're successful with that, then they pick the second one. And what I found is that they're a lot more successful overall, once they've been successful at one behavioral change, they know that they can do the next one. And so that's really a coaching approach to the issue. And I would say having that conversation, learning those, we're going to be working on that. My next book after the implementation book is going to be on wellness coaching with Ferocian Knight. But learning how to have that conversation, and we're going to talk about that again in more of our webinars, but having those conversations and practicing those conversations with your team, so that instead of them, the hygienist telling them, here's how they need to floss, let's ask the question, okay, there's like 3 things that are issues here. Which of these would you like to address first? And, if we get them all done and it takes a year or 2 years to make all of those changes, do I really care which one they do first? Like one day, why do I have to have control of this? If they're going to do it and we're going to do them all, does it really matter to me which one's done first? There are times in terms of treatment sequencing, I want to do the crown before I take the impression for the partial denture. There's some logical things that are requirements that I really can't violate. But if it's something that really doesn't matter, putting the control and the work back onto the patient is where you'll be most successful. And if you just focus on asking questions rather than telling them what they need to do, I think you'll find that will work a lot better for you as well. But I got to tell you, this is it's a new area for all of us. We're not trained how to do this as dental professionals, but it can be done. We're doing it. I'm here to tell you it's not that hard, and a lot of practices are doing it very successfully, mine included. So I'd encourage you to, you're going to run into some challenges and complexities in those conversations, but don't back away from it. Start asking questions and continue to ask us these kind of questions. Give our team here, the people that are the most experienced trainers in the world in terms of coaches for you in your practice to make this successful. Bring that question to them and say, help me with this. Tell me, how do I do this? What does that conversation look like? Give us an opportunity to help you. So I think, Cody, that's probably the best answer I could give to that.
Great, great. Thank you again, Dr. Kutsch, and thank you everyone for all your great questions. Any questions that weren't answered tonight by Dr. Kutsch will be answered in email the next few days. We really appreciate everyone's time and participation. An email will also be sent out with a link to the recording, so if there's anyone that wants to share the webinar with their staff or a colleague, you can do so. And then also feel free to contact us if you'd like to learn more about implementing CAMBRA into your practice or are interested in scheduling a one-on-one webinar. You can get more info as well at the Learn section of our website. So have a great night, everybody. Thank you again.
Hey, thank you, everybody, and I look forward to talking to you again. Good night.